the electronic health record, is sort of like the source of truth. It's the reference document. It's the baseline for continuity of care. If you don't know, if you have not reviewed your records, if you don't have awareness, that's step one, because you have to know what they're looking at.
Welcome to She Really Gets It, a public health podcast. I'm Stephanie Rhodes, a Black woman, public health professional, and your guide to understanding how policies, institutions, and the systems that uphold them harm the public's health, but also how people are coming together to repair that harm and change the system. At the time that I decided to do this episode, I'd witnessed yet another incident of a Black patient being mistreated by a white healthcare provider, which led me to think of all the ways we are made to feel powerless within the healthcare system. One of the ways we are harmed most, however, isn't caught on camera. It's in the stories told about us by healthcare providers to other healthcare providers. Fortunately, many of these stories are captured via the Electronic Health Record System, or EHR. The EHR system is one of multiple systems at play when we walk through the doors of a hospital, and one of the best ways we can protect ourselves and our loved ones is knowing exactly how these systems work. That's why, for this episode, I decided to reach out to someone with experience in advocacy and what to do when that doctor's visit doesn't go as planned. Her name is Kate Hufford, and she's a public health professional and patient advocate with Oregon Health and Sciences Center. The purpose of this episode is to give you, a future patient, the knowledge you need to actually have your voice not only heard, but documented, seen. We start today's episode by discussing who may be telling your story.
The EHR, the electronic health record, is sort of like the source of truth. It's the reference document. It's the baseline for continuity of care. It's important to have providers able to reference things that have come before so that they can make safe and appropriate decisions. Absolutely. However, what I see happen sometimes is that folks forget that in documentation, as they write their impressions, they are essentially creating a narrative. And that narrative is then taken as the source of truth. So what you hope, or what one hopes, is that they stick to really objective things. They stick to really objective, findings. They stick tight to their SOAP notes or their assessment plan, that they are very clear on what is objective information. This was the reading off of this machine, and this is my assessment of that in my plan. And you hope that they're really doing that because the next person that reads it is going to take that in, and they need to some extent because it contains objective information. But at that point, you also hope that the person that's reading it is going to let go of things that are not necessarily objective, that have to do largely with impressions about someone that are subjective. I found them to be aggressive or assertive, or they were angry. If it's not a mental health provider, people should really be concerned about using terms like emotionally liable or disorganized. I think that providers often need to ask themselves what the purpose or what the goal of including information like that is. Because those more subjective assessments can shade how the next person, their assessment, like their plan. If they read that somebody seemed hard to work with, or that seemed, not receptive, or kind of all of these more coded things, they may be more or less likely to assess and to plan for an intervention that requires closer work with a patient. We should pause shortly here to say, if you don't know about this in your chart or a patient's chart or someone's chart, if you don't know, if you have not reviewed your records, if you don't have awareness, that's step one, because you have to know what they're looking at. So definitely request your records, everyone. Take a look at your records, because these things matter, and you have to know what they're reading. And if you see something that doesn't sound quite right, or is super subjective, or there's something else going on, you can ask. Most places theoretically ought to have a way to contest or to ask for an amendment. And that then moving forward, if you encounter a provider who seems to be going off of this undisputed source of truth in the record, that then as a patient, you could say, are you aware that I submitted an amendment request? Or are you aware that I asked to have that changed? And can you please document that in your note? I don't agree with this, or that that's not actually what happened. It's just important to recognize that just by having it become part of your record, then that part gets repeated. That part is taken forward. Then you have a hand. You have some power in shaping what the next person sees. And you don't have to stick into a relationship. You don't have to stay with a provider relationship that isn't therapeutic, that isn't productive. So then you keep it moving.
And I have a question. So we're going to go back. We're going to touch on that again. But first, what does a patient advocate do? So if I'm walking into a hospital, I am receiving care. What are the steps if I ever feel that I need to speak to someone about an issue I might have? What does a patient advocate do? What is their role? How can they help? Where do they live within this hospital?
It's likely going to be different every place you go. Now, if that hospital receives CMS funding, so Medicaid, Medicare funding, they have some way of filing a complaint or a grievance. They have some process by which to do that. That's a safe place to start, to say, hey, concierge desk or information desk, or, you can generally ask anyone, hey, who processes complaints here? Who does your complaints and grievances? And you will likely find the people who are most clued into the hospital's policies, the patient rights and responsibilities, the people who are performing the functions most closely aligned with patient advocate. And there's also a distinction between a patient advocate and a medical advocate, which tends to be, I think, more clinical and private. A patient advocate, if they work for the hospital, then they are likely aligned with, or they are likely charged with having some role in filing, receiving, processing, escalating patient or family, friends, concerns and grievances about clinical care, about service, about just in general a hospital encounter. In my world, it's both inpatient and ambulatory.
So I know, if you have CMS funding, you have to have a way to make a complaint. How could a patient access that? Or could they go to the CMS website? Would they be able to look it up on the hospital's website, or?
Both, I imagine. I'm sure CMS website, government websites, we hope, have information have information about that requirement. Yes. Last I checked, they do. Hospitals should have information, patient-facing information, about how to file complaints and grievances. Even if that's call this number, that's the safest bet. It'll be a call this number. But some of them also have here's a form, here's a link to a form you can fill out, and this is the process we use. And that, honestly, that may be a requirement as well linked to CMS. I'd have to review that again. But there should be some patient-facing information for how to file a complaint or who to call or talk to if you have a concern about care or about service.
Okay. So when we think about the patient record, and if there is an issue with a patient record, the steps would be, from my understanding, is requesting your patient record. Are there any barriers to doing that?
Short answer, yes. There are things that come up. There are certainly unintentional barriers or barriers that are systemic. There could be cost barriers. There could be formatting barriers. If you need an ADA accommodation, I need to be able to get this in a format that I can read or observe. I'm really thankful that the organization that I work for really does try and meet people and accommodate and do the things to make sure that cost is not a barrier, that to the greatest of our ability, we're able to provide people with records and formats that they can access. If the hospital participates in MyChart, they may or may not have the ability to request records through MyChart. But theoretically, places should want to work with you to get you your own information. I worked in the film library at another spot for a long time. Film library is the repository of all of the imaging. So oftentimes places you'll have your written medical records, so all your notes, and then you'll also have, it's part of radiology, so the place that houses all of the images and all the reports. So those sometimes can be left out because they're larger files, because they may need to come in a different format. They used to, for x-rays, give you the entire sheets of x-rays. And those are really important for empowering patients, again, with that objective information. Because if you're not liking, like, let's say you have a broken leg or you have, something going on that requires a lot of imaging, and you're not feeling like you're getting great service or care with where you're at, what you definitely want, and very, very least, is to have your own records of all of those images so that you could theoretically take those to somewhere else and say, here are these, here's the objective information. A lot of times people also can't schedule, or that can be barriers to referrals because they want a chance to look at those. New doctors, new providers want a chance to look at those records, look at those images ahead of time. And so if you can just get the jump on, here you go, already got it, here you are. That's another way of also trying to make sure that the objective information gets there first instead of the impressions. And so if you can get a jump on providing that, you'll probably be quicker to schedule. Just everything will move faster. There's stuff. People generally can work with you to get those to you.
So let's say, so at this point, we've requested our records. We have our records. We see something in it that seems suspicious, or or it seems racially biased or gendered biased, transphobic. Name the number of things that could be in there. And now you want an adjustment because you don't want to expose yourself to even more bias. How do you make a request for a change? And would I go to you for that request, or who would I contact if I find something that I don't agree with or that I feel is harmful?
So getting really clear with yourself about the goal. Like, what's the goal? If the goal is 100% just, I see something incorrect and I want it fixed, likely it's the records department. Those are the folks who, in my experience, actually take the request and talk to the doctors, talk to the authors of the notes, talk to them and say, please change this. Here's the patient's record. Here's the request. Here's the reasoning. Here's the thing. That usually, in my experience, goes through the records department. Now, if also a goal is, I would like to know why this happened, or I would like to know how we're going to prevent this from happening again, then I'm the right person, because then we're going to probably file a complaint or a grievance, or my colleagues and I would be the right folks to ask more questions and to provide a more robust response, and to look into it and to actually try and say, how are we gonna prevent this in the future? Or sometimes also it was a misunderstanding, and here's what we found out in escalating this to various people who are in charge of accountability for things like this, and then we put it all together and we can share it with you.
Okay. And our so amendment requests are not always successful. Correct?
So if success means that they're going to do it, that the change that you have asked for, they absolutely not. They are not always successful. They do not have to grant that request. I try and tell people that, this is your right to ask. However, it's important to know, like, they are not obligated to grant it. So if this is super objective, like you said, it was you said I wasn't bleeding and I required 2 pints of blood, like there are going to be people who are like, oh, what? So things that are very, very solidly objective, I think they have a greater chance of being granted. Things that are tougher are naturally going to be, no one else was in the room. You said this and I said this and you wrote this and that's not what happened. They may or may not grant it. However, in my world, there will be a record that you asked.
Yeah.
And then you have a closer to an even slate of like, okay, well, now it's on new doctor or new provider, a new person to take that into account. And now, we start as close to fresh as we can, or we start as close to even as we can in an inherently, power differentialed system.
I think so many times as a patient, you can feel very disempowered, especially when you're like in what might be the most vulnerable state of your life and not knowing what to do. Even myself, I remember having abdominal surgery, an abdominal myomectomy in my mid-20s. And I talked to the doctor beforehand. I talked to other surgeons about it beforehand. I was like, I don't want staples. If I see staples, I will freak out. I don't want them anywhere near me. So I spoke to a surgeon who said, oh, that's easy. He's like, just ask for the doctor to do Sanisteel sutures under the skin. It'll be like much cleaner. You can do it without the staples. It's better in terms of scarring as well. So I said, okay. So I talked to the doctor, explained exactly what I wanted. He said, okay. Had the surgery, woke up. What do I see? big staples all across my belly. I was so upset. I lost it. At that point, I think I went into like a whole other realm. Like I wasn't seeing straight.
Yeah. Sure.
And so I think he was terrified of me. My mom's like, Stephanie, I think the man is terrified of you. I was like, he should be. He should be terrified. Okay.
Sure.
And so from there, like he literally, he sent in another doctor to see me the rest of the time. He just did. I think he was just like, I don't know what to do, you know. Sent in a plastic surgeon to have a conversation with me. But there was no true like anyone saying like, you know what, you should speak to a patient advocate, or you know what, this is who you should talk to. So for me, I feel like that was before I went to like school, got my master's degree in public health, or even worked in a hospital. I was a baby. And so I had no idea what my rights were. Part of the reason why I'm even doing this podcast and even doing this episode is I think so many times we don't even know what to do in that moment. We don't even know that there is anyone to call. I think sometimes, whether it's intentional or not, hospitals don't always make you aware of all of the resources that are available to you, you know, in terms of how are we going to address this, or rather, how are we going to redress this? Like, how do we get you some type of, before we go to the lawsuit stage or this stage?
Right.
What are these steps? I think it's also important, like, for doctors to know as well. I think so many of them are like, they're kind of taught to, we don't admit we've done anything wrong. There's a certain blaming culture in medicine. You know, it's like, it's this one.
Stakes are high. Stakes are high. Yeah.
Yes. As opposed to how do we actually address this in a manner where we actually acknowledge harm done and we're actually going to do something about it and prevent it from happening in the future. Yeah.
Well, let me ask you a couple questions about that, because that experience, what you're describing, is like, that happens. Like that's something someone would totally call, or I would, they'd stop by the office and I would hear about. So, just in general, like as a general story. So what I would ask first is, okay, short of going back in time and like no staples, doing what we say. First of all, the very first thing I heard was that another doctor told you it's simple, it's easy. They'll just do this. And maybe it would be simple and easy for that doctor to get that done, for that. Like they're thinking already out of the bat. I'm like, ooh, because then you were given this kind of set of expectations, or this, it's simple, it's easy, under the skin, stainless steel, blah, blah, blah. So we're starting off there, that if maybe for that doctor, that's true. And they were empowering you too, to ask for something. That's great. But that's the first thing. And then that was the plan that I'm hearing. That was the plan that was agreed upon. Okay, cool. We go into surgery. You come out. And then it's boom. That did not happen. So something happened at some point between, sedation, anesthesia, and waking up that changed the plan. Yeah. So we know that. Objectively, something changed the plan. So then the question becomes, what would have been, from your perspective, what would have been the ideal response at that moment when you wake up and you go, what the hell is this? All of the feelings, all of the thoughts, we had this plan and this is what I'm seeing. Knowing that we can't go back and can't undo, can't, whatever. What would have been the right way to respond?
Well, first, I think
for you.
So he acknowledged that he forgot. I actually talked about it. He said, you know what? I forgot. He didn't write it. I don't think he wrote it down.
Oh, okay. So that source of truth, so there are similar themes here than the story that we were talking about my mom. Similar things. What was it written down? Great question. Okay. So he acknowledged he forgot.
And for me, the ideal thing would have been he didn't do this, would have been for him to say, you know what? I'm going to cover the cost of a scar revision. Because scar revisions they can be anywhere from, I think, like $500 up to like $5,000, depending on the size of the scar. That would have been, okay, you know what? We can't do it now. We can't do it today. But in 6 months, we can do a scar revision. Covered. Don't worry about the cost. I've got it. That would have been the ideal situation, because you can't, go back in time. But you can be like, I can address this in a way where this is simple, right? That's a relatively simple fix, in my opinion. That would have been the ideal fix for a situation like that. And I think if it were me, if I were the surgeon, I would be like, you know what? Yes, not only do I admit that I did it, I'm going to address it. Like, there are plenty of plastic surgeons around here. Scar vision should be relatively easy. That's a pretty low risk surgery, especially based on the location. Because first he's like, I can't go back. If I go back in and fix it today, you can get there's increased risk of infection and all these other issues.
Right.
But I think he was just so uncomfortable with the fact that I was angry, and I was rightfully very, very, very angry because it's a violation, right, of like your body, of like I didn't consent to this, right, and I wasn't conscious to like advocate for myself or say nope, don't do that. So for me, that was the issue. That would have been the ideal scenario.
And what happened instead?
I mean, he apologized. I spoke to a few lawyers because I was in Mississippi at the time, but Mississippi is a good old boy system. When I spoke to the lawyers, they actually three of them refused to help me because they said, oh, all of our wives go to those doctors for OB-GYN help. And if we do that, we'll be blacklisted. That's like a blacklist because they're all, it's a whole good old boy system of like, of like,
I'm just right out there with
of like white male doctors and white male attorneys who are like all in the same social class, and they are like, no, we can't hold him accountable. That would be bad for us because we're all friends and we work together to avoid accountability. It's a system of zero accountability for a specific class of people. I don't know that Mississippi is unique in that. I think it's definitely like the Southeast in general. I think there's this system of we help each other avoid accountability. I know, but that really was what he said. Mississippi is a place where people are just kind of out with it.
Which can be better sometimes, at least because then you know. You know, versus just wondering or like, or worse, people pretending like that's not, not.
Oh no, it's a thing. Mississippi, I call them the matinee idol doctors. They all that's what my doctor was.
General hospitals,
it's very much like that. It's really weird, actually. Like they're all big and muscly. Like I'm talking about rippling biceps.
Interesting.
Like hair flowing in the wind. Like it's a certain. It's a thing. It's really odd. You don't.
Very interesting.
I haven't observed the same thing in other parts of the country that I've been, but I've definitely observed it in places like Mississippi, Alabama, Florida. Yes.
Florida. Yeah, that's where my brain. I don't have a ton of experience with providers in a lot of different parts, but the ones that are coming by, I'm like, it's funny that you say that. I don't know what that is. I think maybe it's like leisure society, like disposable income, or like oh, this is what I do in my free time. We go, whereas in the Northeast, it may be more like boating, or like these kind of like just different kind of just leisure society. Let's shall we say?
One of our friends said that she was like, Stephanie, I'm so tired of this doctor shit with these like. They spend 8 days a week in the gym, and they're not too concerned about their patients. Not that you can of course be into like your physical appearance and be a great doctor, but there was a pattern of behavior, I will say, that I observed during the time that I was in Mississippi. Because like there are individuals that do not do that at all. They're wonderful. They're great doctors. My mom's anesthesiologist for her cancer surgery was an amazing doctor. Like just really good, like had it together, but she was also a woman. So I think that was
okay.
But she was great when I presented concerns about anesthesia and its effect on my mother's health, because my grandmother had gone under general anesthesia and it had very significant negative impact on her brain health because she was in her late 80s at the time. And so I wanted to speak to an anesthesiologist who had a really great conversation with me about the precautions that she actually took with older patients with general anesthesia, and what precautions she actually took, and like how she actually made changes to the care she provided people based on their age, because she was aware of that.
That's wonderful.
She's like, I can't always guarantee 100%. She's like, but I definitely take that into account. And this is what I'll be giving your mother as opposed to someone who's your age, for example. So it was, so she was very like, talking to me.
Yeah, she honored your your earnest reticence and your uncertainty, and she spoke to it and she took that seriously. That's amazing. That's what I mean. That's ideal in my work. Like from where I'm coming from, that's the bare minimum
and
that I would want.
All the difference in the world. It truly, truly does. Right. It means if something does go wrong, I'm not gonna be quick to be like, you did something wrong. I'm more like, okay, we can talk about what happened. It's a little more, because there's a rapport there, and there's a bit more of a relationship there, and there's more trust there. I think a lot of doctors Some, not all, have this idea of hierarchy. It's a belief in extreme hierarchies, and that's just, I think that's the Western world. It's established on,
Mm-hmm.
Polarity.
Yeah. Yeah.
Polarity and
Yeah.
hierarchy.
Yes, absolutely. Absolutely. And I did this to earn this, and this is what gives me the right to say, do
Yes.
this. Mhm.
Yes.
Yeah.
So,
And there's achievement, there's a lot of stuff that goes into that. I have proven myself, I have done these things, and don't question me, or there's all of these things that can play into it, and that can be like operating underneath the conscious,
yeah.
subconsciously, these expectations, these things, these deferences that people get used to and they bristle at, and then some of those refusals to recognize um, the differences, or the yes or that type of thing, that actually can play out when doctors or providers or whomever are interacting with patients who don't operate in
Yeah.
that world, who don't really, that they just aren't going to do that. They don't, that's not how they live. That's not where their brain is at when they go to the doctor. And then those tend to be, or can be, the situations where the interactions become
Yeah.
difficult, or feel
Yeah.
difficult, or feel like, but the question then is always like, difficult for
Yeah.
who? Difficult because it's hard to talk to someone who doesn't grant the same weight to your 20-30 years of experience, because that just doesn't hold the same cachet for them as it does for your colleagues or for the people that you work with every single day. And the providers that tend to be like more nimble in that, and can sometimes switch between their work selves and their non-work selves, and pick up on those, how to reach people, how to talk to them, how to like be human in a way that's outside of their role as a doctor, as a practitioner, as an APP. Those folks build the rapport. Those folks don't feel challenged by questions. They don't bristle. They want to meet people where they're at. They want to have those conversations. They truly want you to
Yeah.
understand and honor that. Even if you do, there's trust. You got to build the
Yeah.
trust. And yeah, those providers do
Yes.
exist, certainly, but I think that they do have to they have to want to venture outside of
Yeah.
that system, out of the typical merit, out of the typical hierarchy system, and
Yeah.
that's scary.
So I know we're going to be rounding it out or closing out soon, but I had a question for you. Okay. As a patient advocate, if someone's going into the hospital and you could create a task list for them, right? Things to check
Mm-hmm.
off before they go into this hospital so they can feel their best, feel safe, and feel empowered if something doesn't go the way they want it to
Mm-hmm.
go, or if they feel they need to file a
Sure.
grievance. What would be on that checklist? Or what are there, like 3 top items or 2 top items that you would put on that list?
Yeah, before they go, learning as much as they can about the organization that or the hospital they're going into, the organization of the hospital that they're going into. So, is it a teaching hospital? Is it attached to a university? Because that's going to be different. Is it, is it based in a religious organization? Because that could change
Yeah.
things too, depending on what they're going there for. So, learning all they can about that piece, like, is there a board of directors, all of the different things, because it matters. Just knowing, not necessarily needing to know the nitty-gritty about why, but just knowing. And then almost everyone signs terms and conditions of the hospital, so read it,
Yeah.
read it, read it, and like, ask for a copy, read it. It's not going to be unusual if you don't understand all of it, but talk to someone who does, or work it out. Ask questions about it if there's stuff in the terms and conditions you don't understand or you're concerned about. So just make sure that you understand that, and know who's on your team, who's in charge of your team. So if you're going into the hospital for a procedure, let's say it's some kind of ortho procedure, the likelihood will be that the ortho team will be your primary team. But just make sure that you know that, because you may also, if you, depending on what your clinical profile is, depending on if you have diabetes, hypertension, another team, a medical team, sometimes they're called internal medicine or medical team, they may be your primary team. And this matters because they're in charge. They're the ones who are like quarterbacking what's happening. So they may have, consults to other teams. They may, if you have issues, with your kidneys, you get dialysis, they may have nephrology. They're consulting with nephrology, but they're kind of in charge of coordinating. So know who your primary team is going to be. And then within your primary team, and this is where touches on if it's a teaching institution or not. Know who the attending is, because the attending on your primary team is the big boss. It's the person with the most seniority, the most experience, the most responsibility. They have that breadth of knowledge. They have that experience. They have those things. So they will be the one that all of your other team members under that primary team are looking to. They're checking with. They're making sure. So if you haven't had a chance, ask to meet them. It may take a little while. They tend to be very busy. They're with all that responsibility comes more responsibility. So it may take a little while, but that's a reasonable ask. I want to meet them. I want to have a conversation with them. And then find out if it's going to change while you're there, depending on how long your admission is planned to be. If it's going to be, a week, maybe it'll be the same attending, the same folks. But if it's going to be longer than that, you may have more than one. So just kind of knowing that structure, the cadence of changeover, and what the team is going to be comprised of. Are there medical students? Are there going to be residents? A lot of that stuff, too, is touched on in those terms and conditions. So taking a good look at that and making sure that you understand ahead of time. But yeah, know the team. Know your personnel. That's a big one. But that was 2. And then the third one, read the rights and responsibilities. Again, that is likely patient-facing, so maybe on the website, but it's also something that maybe your doctor or whomever, as you're having those like pre-surgical or pre-encounters, or even when you're checking in, asking for that. I'd like a copy of the patient rights and responsibilities, or I'd like to have a chat with someone who knows that really well. So, and that may link you indirectly to a patient advocate. Get your patient rights and responsibilities and take a look at those and ask your questions before things get underway. So know your personnel, know what you're signing, and know your rights and responsibilities.
If you enjoyed this episode of She Really Gets It, please review and rate this podcast via Apple, Spotify, or wherever else you get your podcasts. It really helps people find the show. If you have any topics you believe we should explore in future episodes, you can join my Substack and reply to any of the emails I send out. Links to that will be in the show notes.